Okay, so now we're live. And I'll just hit record. I'll give it a minute or so, and then let participants in.
26.
Okay, now we're live. And I'll just hit record. I'll give it a minute or so. So yeah, that's about 7. So I'll admit that people from the waiting room, and then we can go ahead.
Cool.
Cool. So hello everyone. Welcome to our session on radiology for F1s. So my name's Indra and I'll be moderating the session, and we've got a couple of great speakers on for tonight. So thank you all for joining, those of you on Zoom and YouTube. I've just got a few slides for an introduction to the series, and then I'll hand over to our speakers if that's all right. So this is the Radiology for F1 series. It's a 2-part series that essentially covers everything you need to know for the radiology aspects of being an F1, which is often one of the more difficult areas of the job. Our first session was held in late July, and the recording is available on our YouTube channel, and this is the second part of our series. So essentially, as we mentioned, 2-part series aiming to prepare you for starting F1 and just get you comfortable with the radiology aspect of the job, because often that's the bit that you will have to do. You are often the spokesperson when communicating with the radiology department for your team. And so it's important just to know what you're doing and just understand the basics. So this session will focus on some core radiology cases, both diagnostic and interventional, and hopefully you'll be able to kind of be more confident when you're on the wards. A few of the other things that our juniors are running. So this is just one educational initiative that we're running, and we've just got a few of these here. So for example, our Taste IR is a webinar series just on the basics of IR. We run an application series, a journal club, as well as some research collaborative projects as well. So do check out our website if you want to find out more about some of the other things we run. And this is in collaboration with Mind the Bleep, which is a fantastic resource for all new F1s. So they have a great website which has loads of articles on lots of different specialties, and not just clinical things, but even basic things like F1 pay and things like that. It's a really great website, and they have a weekly newsletter as well. So I'd highly recommend signing up to them. And this is just a screenshot of their website. And so for question answers, we are using Slido as our platform. So there's a QR code or the URL. So if you head over to Slido and just have that open, and then we'll take your questions from there. And at the end, please do let us know how we did. It's the first time we've run this kind of event this year. So all your comments and feedback would be really welcome so we can improve things for the following years. And so now I'll stop sharing and just hand over to our speakers.
So I'm just going to unmute myself. Hopefully everyone can see my screen. I'm just going to start slideshow. Okay, so can you hear me? Well, thumbs up. Cool. So my name's Imran, or Dr. Lasker, or Doc Lasker, whatever people call me these days. I'm going to be doing hopefully a fairly quickish talk on, I guess, scenarios, what it's like to be an F1, or a junior doctor when you're running around on the wards trying to interact with someone like myself. Radiologists can be a little bit mean, I'll be honest with you. I'll try and be one of the nice ones, but it can get a little bit difficult sometimes. So hopefully going through some of the things you can understand why some of us can come across mean when we're not trying to be mean. And the main point is to really talk about the scenarios that you guys are going to be finding yourself in. So you're going to be in hospital for the first time, actually working there as an F1. And a lot of your job is going to be requesting scans. And when you're requesting scans, you're kind of trying to communicate between your team, i.e. the consultant or your senior, the registrar, and the radiologist. And it seems a bit weird, doesn't it? Like you're basically being a messenger service, going from one person to the next person. Radiologists might say, no, I'm not interested in what you're talking about. And then you end up going forward and back. It can be really irritating. And I remember when I was doing it, I used to feel a bit like, wow, my time's really not worth that much if you're going to get me to walking up and down these corridors. But there was a learning process behind it, and actually it led to the path of me doing radiology, which I highly, highly recommend as a career, intervention or otherwise. So I'm going to go through, requesting scans, kind of what you need to be asking for, what it can be like out of hours, because that's actually when it gets a little bit stressful for everyone involved, your seniors, the radiologist, yourself walking, coming forward and backwards with sick patients and that kind of thing. And then I'm going to try and do a little bit of teaching, but doing that teaching, talk about the types of scans and a little bit about contrast and the phase of scans and things. And hopefully that will make a lot of sense. And if it doesn't, please feel free to message me. So your age-old scenario, you're this person, you're on the wards and you're getting asked to, come across and talk to the radiologist because I want a CT scan of the chest because I've got chest pain. And you think, right, I'm going to write that down on my notes and I'm going to go and find that person, that radiologist. And then you've got to find the radiologist, either by phone or physically. I guess these days it's by phone. And the radiologist is being really, really difficult. They're asking loads of questions. You're sitting there thinking, look, I don't even know what's going on. Can you just say yes to the scan? That's all I want. But you have to really understand, the reason we're asking questions is because there are so many kinds of scans that exist and so many kinds of scans that may be useful and may not be useful. So that's why it's important that we ask questions, and hopefully you know a lot of the answers to the questions that we may have. So some of that trick is to really try and think about where the radiologist is coming from. And hopefully from this talk, we'll be able to go through that. Now, one of the phrases that radiologists don't really like is when you say, look, my consultant wants it. Because then it's a bit like, look, I don't really know very much. I've just kind of said, I've got to do it and you've got to do it. And that's not really a nice way to have that interaction. So what I want you guys to do is try and avoid saying that phrase, my consultant wants it. Try and figure out why you want that scan. And in reality, there's only so many things you're going to be looking for when you're asking for a scan. But keep things simple. Keep things really simple in your mind, all right? You want the age, the gender, if it's appropriate, what the patient came in for, right? If they hit their head and the consultant says, I want a CT head scan, you're looking for trauma, you're looking for bleeds. That's all you're asking for. If they're confused, you're looking for an organic cause for that. You got to try and figure out what your team is actually wanting and what they're looking for. So even if your consultant says, look, get this scan, on your walk down, think to yourself, the radiologist is going to probably want to know what I'm trying to find. Try and think of it as this scan is going to prove what I think is going on, rather than I'm just trying to find something. I want to find everything and anything under the sun. Try and think about what it is, even if you make it up. Even if you think, well, I think this patient's got consolidation and that's why I want the scan. At least that's something. But just saying, I'm not sure what's going on, I just need a scan is not all that helpful. And I'll explain why in a few seconds. But my point is, try and think about it from the radiologist's point of view. And a little trick is that radiologists really feel like they're super, super involved in the entire process. They want to feel as though they're the pivot that makes that difference between diagnosis, all the way to diagnosis. They want to know that they've had a big impact in the entire situation. So the better thing really is to say, hey, radiologist, can you give me some advice about what scan I would require? Yeah, and then, you kind of get those the wheels in the radiologist's head going. If you come and say, look, I want an MRI scan, that's when the radiologist's like, yeah, go on then. Why do you need an MRI? You explain yourself. So it's better to go in, look, this is what we think, but we want your advice. So that little phrase can make a big difference with your interaction with the radiologist, just an insider tip. But keep it simple. In reality, most scans, not all scans, are looking for cancer or infection. Yeah, sometimes you get a trauma scan and then you'd be like, yeah, I'm looking for broken bones and bleeds and all the rest of it. But generally speaking, you're looking for cancer or infection. And then, I guess traumatic injuries is the other thing that you're looking for. And with those things in mind, when you're trying to get that situation, like, what am I asking for? If you just go through those two things, you're most of the way there to getting your scan. Now, out of hours, things can get a little bit difficult, depending on where you work, because some places will have scans that other places don't. So a few places where I was working in, which is like a neurosurgical center, where they've got spinal surgeons around the clock, they'll do MRI scans for the spines throughout the day, all day, every day. Some places won't do angiograms, which is a different kind of scan for the head. They won't do that at all hours of the day because they don't actually have a thrombectomy service. They don't have anything like that. So depending on where you work, you might need to know like what kind of scans they are willing to do out of hours. Some places won't do CT-KUBs, which is scans looking specifically for renal stones. They don't do those out of hours because actually a lot of the time urologists aren't going to come out of hours and go and do a procedure. There's actually very little point in doing those kind of studies. So you have to try and understand that, especially out of hours, you've got to be thinking about, okay, is this going to make an immediate clinical impact onto the patient's care? And if not, it can probably wait. But you just got to think to yourself, okay, what is available to me right now? So what you'll find is actually, out of hours, things can be really, really difficult for everyone. Usually you'd have one radiologist, maximum two, but one radiologist that's covering the entire hospital. Surgical team will contact you. You've got phone calls from the A&E team. There's loads of phone calls, and you're trying to report loads of scans, and get really, really difficult sometimes from the radiologist's point of view. It's like the best way I can describe it is like, especially out of hours, if a radiologist is doing a night shift, can you imagine if I woke you up in the middle of the night and said, hey, can you wake up and do the Sudoku puzzle? Can you do that for me? And as the night goes on, you're going to get pretty tired of doing Sudoku, but that's what you're asking us to do. You're asking us to look at a very, very complex study, put the pieces together and tell you what we think that you need to know out of hours. So as the night goes on, you can imagine you start to get a little bit grouchy. You think, I just don't want to do these scans anymore. And so that just understanding from each other's point of view, why it's difficult from the radiologist. I know it looks easy because, we're sitting there suited and booted, watching, watch on and all the rest of having a coffee. But actually, your mind's constantly whirring away. Now, I remember what it was like being an F1. My mind wasn't always on. I'll be honest with you. A lot of the time, it wasn't on at the best of times. I was putting a cannula in, putting, fluids. I wasn't thinking all the time. But as a radiologist, you can't afford to not think. You miss something, and that can have very detrimental effects on patients. And so I still remember the days when I was doing the night on calls. I had the surgical team come in and say, listen, based on what you're saying, we're going to take this patient into surgery. Are you sure about that? And you're really thinking, oh, you know what? I'm not sure, depending on how confident you are. So there's a lot of responsibility put on the radiologist, and that's something that sometimes I feel people forget. Now, try and be polite. That's really basic. I've had young F1s and F2s come in and try and tell me off, or be very, very rude, as if like it's okay, but it's never okay to be rude both ways. So if a radiologist is rude to you, I'm not saying be rude back, but you should bring that up. You should tell your seniors about that, because no one should be rude to anyone, even if things get difficult. Sometimes things can be a little bit jarring, like if some radiologists, not me, I mean, I admit it, I do make mistakes, I make typos, all sorts of things. It happens. But some radiologists don't like that idea of making a mistake or someone telling them they may have done something wrong. So if you've noticed they made a typo, just, call them up. Don't say typo, say, I just need some clarification on the report, please. If you think you've spotted something, now believe it or not, I've actually had F1s come in and tell me, we think you might have missed a stone. And lo and behold, they were right. I missed a stone. They looked at it, I was looking too quickly, and they saw it and I didn't. Those times, don't say, look, I think you made a mistake there. Say, look, do you mind just having another look and explaining to me what you think that thing is? Because I was worried it could be a stone. And if your radiologist is okay and is willing to admit to a mistake, then usually they're okay. I mean, it's in their best interest and the patient's interest to say they're okay. It's just a way in phrasing it. Don't say, I think you made a mistake there. Say, do you mind just having another look? Could you give me a bit more clarification about something you've written in the report? And then it kind of comes across nicer than, you've made a mistake, I think you need to deal with it. Oops. So out of hours, like I said, not everything's available all the time. Not all MRIs are available. Nuclear medicine's not always available. Ultrasound's not always available. And not all CT scans are going to be available because, not everything is an emergency. Not everything needs to be done straight away. Now, teleradiology, for those of you not aware of, there are big companies, Everlight, Fourways, Medica. These are big companies that exist, and they do a lot of hours work. I work for some of them, and they do a lot of the work for us in Basildon as well, out of hours. Now that's when things can get a little bit murky. They get paid per scan. Every single scan that comes through, they get paid per scan. So you can tell that it's within their best interest to let every single scan through. So you may end up working for a place that employs teleradiology services to do the out-of-hours scans. And in those situations, you might find it a lot easier to get the scan that you want, even if it's staging, even if it's not something that you think needs to be done. In fact, some places may even say, wait till after 8 o'clock. That's when teleradiology kicks in, and then you get the scan that you want. And it's true. That's the way it is. When you incentivize that way, things can get a little bit murky. The difficulty for you guys might be that you may move from somewhere that does teleradiology to a place that doesn't. And all of a sudden you go from being used to getting whatever scan you want, especially after 8 o'clock, to suddenly having a few questions to be asked as to why on earth you're asking for these scans. So just be aware of what services that you have radiology wise. And you may notice that between certain hours, things are a bit difficult to get. And between certain other hours, it's a little bit easier to get. I'm not saying play the system. I'm just saying it's something to be aware of when you're doing out of hours work in some places. So look, I just thought moving forwards, let's give a scenario to you guys. If you got a patient, let's say they're 50 years old, they got chest pain, right? Most of the time, usually you're going to get a chest x-ray, but the chest x-ray looks normal. So you're right. You think to yourself, I think I need to get a CT scan. Now, you got to think to yourself like, all right, I'm going to get a CT scan. How many CT scans exist in the realms of CT chest? Because for you guys, asking for a CT chest is asking for a CT chest. You come in and say to me, Dr. Lasker, I got a patient and they've got chest pain. I need a CT chest. And then you've got to start thinking about, from my point of view, what does a CT chest mean to me, right? A CT chest is just a CT, right? A chest is just a part of the body. So just zap the patient. What more do you want? It's a little bit more complicated than that. It really is, I promise you, and I'll show you. CT chests can be CT pulmonary angiograms. You're looking for a PE. All right, chest pain, PE. I get you. Oh no, but CT chest plus contrast could be looking for infection. So you're looking consolidation, empyemas. Okay, that's a different kind of scan. I get you, fine, we can do that. Oh no, you think about malignancy. Malignancy could cause pain. I mean, could it be eroding the chest wall, eroding the pleura? But then in that case, if you think it's a malignancy, you need to do a CT chest with contrast and include the liver. The liver, why? Because metastases can go to the liver first. So we do CT chest plus contrast and the liver. Oh no, you don't think it's any of those things, but you think they could have fungal disease because they're immunosuppressed. In that case, we do an HRCT, a high resolution CT scan. You think it'd be interstitial lung disease, then you do an HRCT. Oh no, actually you think it could be a tearing central chest pain and they've got different blood pressures. You're talking about an aortic dissection now. You see what I mean? Your CT chest can mean so many different things. All of a sudden, your single CT chest can be 1, 2, 3, 4, 5 different things, depending on what you think it could be. So why is that important? I mean, look, CT scan with contrast, how important could it be? This is the next that's the next concept I'm going to try and introduce to you guys. So let's say we've got this patient, they've got central chest pain, they've had recent travel, they're on the pill, and they're hot and clammy. So I'm pushing you guys to think of a certain thing. I'm making you think, okay, this could be a PE. I want a CTPA, right? CT pulmonary angiogram. But what is a CTPA? What does that even mean? CT pulmonary angiogram, pulmonary arteries, right? So I've highlighted that little section there. When you inject that contrast, we wait for that contrast to be in that particular area there that I've highlighted. And then we trigger the scan to go. And therefore, the contrast is going to be sitting within the pulmonary arteries, not the aorta, not the left ventricle, in the pulmonary arteries, because we're looking for a PE sitting within the pulmonary arteries. Now, imagine if you had someone who's got aortic dissection. You want a CT aorta, that's a different compartment altogether. But you've just gone and asked for a CTPA, but you've got an aortic dissection. Does that make sense? You're in the wrong part of the body with regards to the contrast. Contrast is just liquid that goes through the artery, it goes through with the blood and carries on with whatever part of the body you want. So depending on the timing of the contrast, you get the kind of scan that you want. So if you want a CT aortogram, you put your little signal thing there, you wait for the contrast to get there, and then you take a scan. If you're looking for CTPA or for a clot, a blood clot within the pulmonary artery systems, then you wait for the contrast to be there. Now the difficulty can arise with this situation here. So now I've shown you, I've told you there's CT aortogram, there's CT chest with contrast. What kind of scan is this one? Right, so let's get back to anatomy. This is the aorta. This is the aorta. This is the main pulmonary trunk and see in the pulmonary arteries. And the contrast is very, very bright. That's the whole point of contrast, and it's sitting within the pulmonary arteries. So therefore, this must be a CT pulmonary angiogram. We're looking for a PE in this particular situation. Right, But then we couldn't see a PE, but as you come further up, you can see that there's a weird linear density that is sitting over here. What part of the body was that again? That's the aorta. So you've got to bring that patient back again and do another scan. And lo and behold, they've got an aortic dissection. So you can see how important it can be to get the right scan for the right patient. And depending on the clinical history, you can hopefully figure that out. And so this patient had the wrong scan. Maybe a little bit more clinical history, maybe measuring the blood pressures between the arms could have made the difference. But they had the wrong scan and having had to have 2 scans for the problem that they turned up with. So that's why it's so important to know what's really going on and what you're really thinking of. So let's go to this one, abdominal pain, right? Abdominal pain, that's what you think is going on, and you're trying to figure out, now you're thinking they've got right upper quadrant pain. Now let's take a step back from my scenario, because I like scans, I'm a real scan geek. You're looking at this particular scan, what do you think? What on earth is going on with this particular scan over here? Let's get a pen. Hopefully you can see that there are these weird looking lines that are sitting over here. Now what people don't realize is that they kind of get dissociated with what's really going on. People think that radiology is pattern recognition. And of course, it is. It is a lot of pattern recognition. But once you get past the pattern, what do you do next? If you've never seen that before, what do you do next? Now, maybe some of you know exactly what those weird linear things are, but some of you may not. Now, where do you go from there? Is it bowel? Could it be bowel? Can bowel go from inside, from all the way down here, all the way around like this, and all the way down there to down around the legs? It can't. So what else could it be? Could it be the aorta? Could the aorta be that wide and go all the way down like this, all the way around? Probably not. So now you've got a patient who's got abdominal pain and you really don't know what on earth you're looking at. But try and remember, we're looking at 3D structures of 3D people. These are 3D people, right? So we're looking at 2D pictures of 3D people. What else could it be? Skin folds. That's all it is. There's just skin folds. But you can get confused, you start to panic because you think, okay, what on earth is that? But to go back to basic principles, what anatomical structure can go from inside the body to outside the body? Not very many things, but skin fold can. It can look like that, but it doesn't. But now let's come back to the scenario. We've got right upper quadrant pain. What are we going to do? We're going to get a CT scan. But you're going to say, look, I want a CT abdo-pelvis. That's all I want. What's so complicated about that? But just like the last patient, it could be CT KUB, kidney ureters and urinary bladder. But that's a non-contrast study. You're looking for a stone. But it could also be just a CT abdo-pelvis in portovenous phase, which is, I know it sounds like gobbledygook for now, but I will explain. But it could be an arterial phase image if you're looking for ischemia, ischemic bowel. It could be nephrogenic phase because you think something's going on with the kidneys. It could be a CT aorta of the abdomen because you think it could be an aortic dissection or abdominal aortic aneurysm. You see what I mean? A CT abdo-pelvis can mean so many things to me, but to you, it's just a CT scan. But we've got to think a little bit more depending on what you think is going on. So now when we look at this study, right, I'm just trying to explain to you guys, remember what I was showing you contrast with the CDPA? Now, where's the contrast on this study? The truth is there is no contrast. This is the aorta that's sitting over here. It doesn't look any different from the liver. It doesn't look any different from the kidneys. Now have a look at the bone. That's high density. That's hyper dense because it's bone. Calcium is dense. But in this particular study, we don't have any evidence of any contrast anywhere. However, when you go to this study, now you can see there is a difference, previous to current. But now, okay, which phase of imaging is this? The aorta looks very, very dense. Compare it to the bone next to it, it's almost isodense, almost the same density as bone on this particular sequence, on this particular image. So we're actually looking at the arterial point where the contrast is mostly within the aorta. And therefore, this must be an arterial phase image. But notice how I'm sitting around the region of the liver. That liver, that's a portal vein. And this is definitely denser than the portal vein. So this has to be an arterial phase image. Now we come to this particular sequence of the same patient, and you can see that this and this are almost identical with one another. Therefore, this is not an arterial image, not an aorta. This is actually a portovenous image. So I'm just trying to show you that you can actually try and cater the scan for what you're trying to find. If you think it's an aortic problem, go get an aortogram. If you don't think so, if you think something else, then go for a delayed image scan. And then there is actually something else where you actually get 2 boluses of contrast at the same time as one another. And if you time it correctly, you can have both things as dense as one another. The portal vein and the aorta is about as dense as one another. And that's actually called a Camp-Bastian protocol. And I've actually done a YouTube video on that one if you're interested. But anyway, moving on. You've got a patient with right upper quadrant pain. They've got deranged LFTs, right? And they're hot and clammy. You think, all right, what's going on? What do you think could it be? Well, it could be calculi. It could be gallstones, right? So people think to themselves, you know what? I'm going to get a CT scan for that. Actually, in reality, it's better to get an ultrasound scan or an MRCP, but most time you get an ultrasound, because ultrasounds are better for looking for stones. Because what you may not realize is that stones are sometimes very, very fat rich. If they're very, very fat rich, then they're difficult to see on a scan when you're looking for things that are dense or hyperdense, or slightly less dense than one another. So looking for stones is actually better to do with an ultrasound scan. So here we go. We've got someone who's got deranged LFTs and they've got right upper quadrant pain. We've done the ultrasound scan. So what I'm showing you here is the liver. All right. So this is the liver over here. Oh, sorry, it's going to slow down a bit. So you've got the liver over here, and then you've got what looks like the duodenum. I'm going to tell you now the gallstone. Oh, okay, hopefully that's working. Sorry, it's going to be a little bit slow because the scan coming up has got a few images. So you've got the liver over here, and then you've got what looks like the duodenum, and you've got this it's not hyperdense, hyperechogenic. So when you're looking at ultrasound scan, you're looking at hyperechogenic. So there's a hyperechogenic stuff that is sitting around here. You can see that, right? So what is hyperechogenic on an ultrasound scan? It's actually air. Air can be hyperechogenic on an ultrasound scan, and dense structures like calculi can be hyperechogenic on an ultrasound scan. But a calculus is not going to go between the duodenum all the way through like this. So this must be something else. This looks like air that's traveling between the duodenum and out. So that's the lumen over here. It's going all the way out like this. So the person that you thought may have gallstones actually doesn't have gallstones at all. That's air going through the duodenum, which is actually a perforated duodenum. Now this is the CT scan. Now just go back to basics. This is the chest, this is the lung, and the lung is going to be full of air, right? We all know that. If it's not full of air, then you've got issues. But as you come further down below the hemidiaphragm, you can see some of this more black stuff, which is air below the hemidiaphragms. It should not be there. Look, as you kind of keep going, a little dot over here, a little dot over here, and a few more little black dots over here. These black dots should not be there, right? As you coming further and further down, you can see there are multiple black dots all over the place. And you think, okay, so they've got a perforation. There is free intra-abdominal air in this patient with abdominal pain. Something's perforated. Most of the time it's going to be bowel. And what we saw in the ultrasound was actually some air that was going beyond the bowel wall or the duodenal wall. Now, if you pay attention to this area here, you can see that a little bit of this black stuff going beyond the bowel wall and out. And I'm going to scroll through up and down. You can see that just over here. So that's the perforation that we saw in ultrasound. So what we thought was right upper quadrant pain for gallstones actually ends up being a perforation. And as you scroll through, I'm going to just show you another trick of the trade. You can see all this stuff over here. This is fat. And look at the fat over here, very, very black. But over here, it looks very, very hazy. That's called fat stranding. So that shows you there's inflammation within that region over there. So if you saw nothing else, but just saw that inflammation in the right upper quadrant, you know there's something going on. But when you look at that gallbladder, that all looks very normal and very, very thin. So this is actually a perforated duodenal ulcer, and that's why this patient came in. But you can also see that how, right upper quadrant pain, deranged LFTs, et cetera, can be red herrings for what it could really be. And how the imaging can really help you try and figure out what's really going on. But we can only get the right imaging based on what you're telling us and what your consultant is thinking. So really, really important to make sure that you have an understanding as to why the scan is happening, what you're looking for, and what your theory is. So what's my conclusion? Radiology is awesome. It really is. It really, really is. If those of you guys haven't thought about it, I implore you to think about it. It's just awesome. But all jokes aside, I hope this has been useful. I'm trying to show you that things are a little bit more complex from everyone's point of view. From a radiologist's point of view, you're telling me you need a scan. I need to figure out which kind of scan it is and what's going to be the most helpful for you. And we're both trying to solve the clinical picture together. I'm getting what you're telling me, trying to mold it to this kind of scan that I think you need, and then hopefully reading that scan and giving me the answers that you need. So try and go in with the idea that you've got an open mind, you're trying to collaborate. Never take things personally. Even if radiologists are being mean and they say to you, you know what, you have no idea what you're talking about. I would never say this to someone, but I've had this said to me. You have no idea what you're talking about. Maybe you should go back to your team and figure this out. It's not personal. It really isn't. It never is. It's always about trying to find out what the best scan is for the patient. And sometimes, maybe there's a communication problem. But if you kind of go through that simple idea, age, gender, what you think it is, why the patient came in, cancer versus infection, trauma, maybe you thought they'd broken something or bled somewhere. You go in with that idea, then usually you'd get I'm not saying get the scan you want, but you get the scan that the patient needs, not what you need, and that's important. Try and think about the patient first. It's really easy to say when you're not in that situation. But I used to find that when I used to go to radiology and they said no to scan, I used to feel like I've done the wrong thing. But actually, what you're trying to do is get the best scan for the patient to get them further along the patient journey and out the hospital and hopefully back to their normal life. Anyway, I think I am just about on time. So I guess these days people find me on Twitter. So you can find me on Twitter at @Lasker. I'm happy to take any questions if there are any. And hopefully that was useful for you guys. Yeah, so are there any questions? Do I open the chat function for that, or is there something else you're using?
So we've got Slido, but it doesn't look like there are any questions.
Okay.
Thanks so much, Dr. Lasker. Really good run through of some of the common things that you find as an F1.
Yeah, no worries.
We'll move on to the second bit of our talk, if that's okay.
Yeah, no worries. Thank you very much. I really appreciate the help. Appreciate you having me. Yeah. All right then. Bye.
Bye. Thank you.
So we'll move on to the second part of our talk, and that will be more of a focus on interventional radiology. So I'll hand over to Miraen for that.
Okay. Is it showing up? Sorry, first time.
Yeah.
So just go on the presentation. Okay, cool. So I think that was really good. So who am I? So I am starting radiology training in 3 days, and this is sort of what I've done in F1, F2, and an extra F3 to give some credential to what I'm about to talk to you, because all of the cases that we'll go through is something that I've had to request in my last 3 years of being a doctor. So we'll cover 4 of the most common scenarios that I encountered in foundation training. So before we start, I wanted to just highlight that the part 1 of this series was done by my colleague Neil, and on top of being an F1, he's also a radiographer, so he had a lot of extra insider tips that I would recommend you go back to watch if you haven't seen it already. Okay, so this is just to give you an idea how IR will feature across your rotations. So I'm sure everybody will have at least one of the rotations on here, and somehow or other, I'm sure you'll come across IR in your next couple of years. So to get the ball rolling, I'll just go straight into the big guns, I guess, which is vascular surgery. So the first thing that really stumped me when I started my F1 in vascular surgery was what's the difference between these words? So really, angiography versus angiogram, they're probably the same thing. Angiography is the act of getting the images, and the image is called an angiogram. So the way I think about it, angiogram, Instagram, those are the pictures. Now, angioplasty, the way I remember it is plasty like party, and we have balloons. So it's involving balloons in the technique. And stents would be, I guess, a traditional stent that you would think about. But I'll cover all of this in a little bit more detail. So let's go to angiograms. So angiograms are essentially an X-ray test of blood vessels. What we're trying to find out here is the vessel blocked? Is it stenosed? Is it dilated abnormally? This is what a typical picture will look like. It's contrast put in the area of interest and then taken like an X-ray. So in this particular scan here, you can see that this part, the contrast is no longer flowing, so it's a complete obstruction of the common iliac artery. How are these images obtained? So usually patients come in as a day case, or they're already an inpatient and they stay for a few days. So sometimes they go home on the same day, sometimes they stay maybe overnight. And the bed can be in the IR suite if it's the same day, or if they're staying overnight, most probably on the vascular ward. So the way we get to these arteries of interest is via a wire that's going through your groin, so femoral access, or through your wrist, so what we call radial access. These procedures take maybe half an hour to 2 hours, depending on how many areas you want to look, or is there any tight stenosis or bends that they need to navigate the wire through to inject the contrast and get the images that they want. So it varies. Common risk and complications, so obvious ones are bruising, hematoma, false aneurysm. So bruising and swelling. So bruising can look like this, quite dramatic, but the main thing is just to take note and observe and make sure it doesn't get worse. So the idea is, it gets better. If it gets worse, then let someone know and we can think about it again. Hematoma, false aneurysm, so can be quite difficult to differentiate. False aneurysm is where there's a false passage that's formed in the vessel wall. So maybe when the wire is coming in or going in, there's been a little bit of a nick, and there's just been a collection of blood there. So causing often a pulsatile swelling, or it could be a generic hematoma. But on clinical exam, they're probably quite difficult to distinguish. They just probably look like a lump. I mean, you can try and feel if it's pulsatile or not, but ultimately you probably want to get some from imaging and senior input relatively quickly. Generic advice that we say to patients following these kind of procedures is to avoid any heavy lifting, don't drive home the same day, get someone to pick you up. The main idea is to ensure wherever we've put a hole through heals and you're not bleeding from it, because obviously we're puncturing through skin direct into artery. Okay, moving on to angioplasty. So like I said, this is the one with that sounds like party and there are balloons involved. So I'll play this short video. So the general idea is the patient is often awake or under light sedation for this procedure, local anesthetic to the area. We use catheters to introduce wires to guide us to the vessel of interest, put some contrast, make sure we are where we think we are, put this balloon in, deflated, inflated at the region that is the nose, deflate it and remove it. And this can be done a few times in the same procedure over the same site. And it could be that this is all that the patient needs, or it could be that, okay, we've done this, it's widened the channel a little bit, but I'm not sure it would hold. So we think about putting a stent in. So this part maybe takes another 45 to 60 minutes, depending on how tricky it is to get the wire to where you want it to be. Complications, again, similar with the extra complication that there's a risk of vessel rupture intra-procedure, but very rare. And there are several ways to salvage this, such as a stent or moving on to an open operation. So move on to stents. So stents usually in arteries, like I said, put in, deflated, inflated with a balloon, and then the stent stays while the catheter is removed. And usually metallic, made of various materials that has maybe some anticoagulation properties, so it doesn't get thrombosed, and often in conjunction with balloon angioplasty. The main thing for this is after procedure, they need to lie flat for 4 hours. Usually they're in the IR suite for the full 4 hours before they get moved onto the ward. But for whatever reason they're on the ward, and they're wanting to get up and run, we want them to be flat at least 4 hours, mainly again for the puncture site. And at the end of the day, people who are requiring this kind of procedures, often vascular paths, and any opportunity to encourage any lifestyle changes would be good. Okay, moving on to the second thing that you might encounter as part of your foundation training, central venous access. So I've put a few squares here to suggest where you might have to request one of these. The idea of this is it is a longer term cannula. So for whatever reason you want longer term IV access, maybe they can go home and then come back, etc. You want to consider more central venous access. So IV antibiotics, chemo, hemodialysis, or TPN for maybe someone who's post-surgery or has any other bowel pathology. Top tip, most central lines you can access to draw blood if you're struggling with venipuncture for whatever reason. Get someone to show you early on, and it'll be a skill that will tide you through the next couple of years. Some patients are very precious about it, to respect that, and as long as you're competent with it, then I think it's worth having a go, because why poke patient again if they already have an access you can take blood from. The procedure is quite simple. Often they're awake for it, or again sedation if they require. 15 to 30 minutes, inject local anesthetics to the area, scan it with ultrasound, make sure you're at the vessel you intend to go into. And often after the tube is put in, you check with x-ray or ultrasound. There's two main different ones. One is PICC line and Hickman. So both of it access the central venous system, so close, big juicy veins close to the heart. The PICC line goes mostly in the arm, so it's peripherally inserted, and the Hickman is more close to your chest or your neck. And there's two types. One is tunneled and one's not. So tunnel just means that the end bit of the line before it comes out to the port where you access to put things or take blood out is buried under skin for further security, so it doesn't move out of place or fall out or anything like that. Okay, moving on to the third one, nephrostomies. So urology, A&E as well. The main way that you get to, or you want to, get someone to get a put nephrostomy in is after you've already done some imaging, and this could be ultrasound or CT. So you can see the ultrasound here. This is probably what a normal kidney would look like, and this is a kidney with some quite significant dilatation in calyxes, so probably suggestive of an obstruction somewhere. Again, this is quite different between the left and right kidney. So the usual causes for obstruction is stone, can be benign structures or tumors, and that doesn't necessarily have to be the kidney tumor. It could be other organs in the pelvis that's compressing on a ureter at any point between the kidney and the bladder. There's no real contraindication to having a nephrostomy put in, apart from, if you've got some bleeding disorder or if you can't stay still. So I'll talk a bit more about how this goes in. So before you get to the IR suite, most patients will already have some from a broad spectrum antibiotics, often gentamicin, but have a look at your local microguide. You want to refer it quite early to your IR department. Often there's one person coordinating all the referrals. Is it something that needs to be done today, or is it something that can be done on the next nephrostomy list? So often trusts have 2 or 3 lists a week, and we say that if the tube is in between 1 or 3 days and they're hemodynamically stable, that's probably good enough. The procedure again done under local anesthetic or sedation. The patient is prone, so face down on a bed, or they could be on their lateral side, so lying on their side. You use the ultrasound to identify where the kidney is. Then you put the catheter, put some contrast, make sure this is an obstructed kidney and it's enough space for us to put a tube in. And you want to keep the drain in. So after that, usually you get some urine, and it's probably worth collecting that for MCNS to further guide your antibiotic treatment. The drain is actually sutured to the skin, so it's quite secure, and you have various dressings in place to keep it where you want it to be, but it can still move, and common complications are that it falls out for whatever reason. If it does, then just let someone know. Depending on how long it's been in or how long the procedure was, there could be a direct easy just replace it, or you might have to reschedule for another procedure further down the line. The tube can stay in for up to 3 months before you need to change it, if it needs to be there for longer than 3 months. But so after 3 months, you want to consider a new tube for infection and other causes. It can be very often blocked because of debris, like a normal catheter through the urethra down below. So it's worth having a flush before asking for an exchange. And in terms of complications, infection as a foreign body, bleeding is rare, but in the first 48 to 72 hours, depending on how the procedure goes, you might have some pink, like a rosé color to the urine, and that's okay. But if it becomes frank hematuria, then let someone know. The main complication to be wary about is that because of the way that the nephrostomy is inserted there, just above or under the 12th rib, there's a risk for pneumothorax. So if they suddenly start struggling with breathing, or if their sats drop, then it's worth to have this at the back of your mind and get a chest X-ray. That's all. Okay, last but not least, abscess drainage. So this again, where you could encounter it. The only caveat to this is that sometimes it's not the interventional radiologists that perform these drainage procedures. It could be that you have a gastroradiologist that's trained to do the procedures, and it could be within their remit to do them. But each trust is different, so just get to know your radiology department and who's the person to call. So often these procedures can be ultrasound or CT guided, depending on where the collection is. And whatever the person performing the procedure is more comfortable with. So this is a fluid collection just above the bowel, and you can see the needle introducing here, trying to get access to the fluid. Similarly here. The indication for requesting an abscess drainage is that you have an imaging proven area of collection, and you have a collection that's suitable for drainage, and therefore the contraindications if this collection is not accessible by any imaging or needling technique. An abscess can collect anywhere, so most commonly secondary to diverticulitis or any Crohn's or IBD type disease. It could also be post-op surgical fluid collection, but also very useful is retroperitoneal abscesses, so easy access for us, more difficult surgically. So just to talk about the procedure a little bit, again, it could be under local sedation, ultrasound or CT, depending on the person performing it. Very important to ask or certainly make an arrangement with the radiology team as to who's going to request and who's going to collect the sample for MCNS, because this definitely really alters the antibiotic regime that you give to the patient. Again, the drain is sutured to the skin, and there's often quite a good number of dressing around it. And often you get a little bag like that that the patient leaves the IR department with. Aftercare, generally take it easy for 2 hours. You want to do some observations. They can then mobilize and eat after that in the same day. Often the team who's looking after, who's requested this, will have a look at the output every day. And if you come to a point where that kind of ceases or stops, you want to check, is this because all the pus has been drained, or is the tube blocked or kinked for whatever reason? And if, it's worth just giving it a flush to see which is the case. Often you will have some form of repeated imaging before you attempt to remove the drain. And the drain usually stays in for a couple of days or up to sort of 2 weeks or so. And the antibiotic continues while the drain is in there. And you want to chase it, the first 3 days, you send it to the lab, chase it to make sure you're on the right antibiotics. Complications, again, infection, bleeding, because it's a foreign body and you've made a hole. But otherwise, not many side effects or complication, because it's quite precise. You're doing it under direct imaging guidance. Okay, so my last sort of pulse for all of you. The main thing to do is to consent the patient. Obviously, this might be your registrar, your consultant having a chat, but there needs to be a consent form. So some departments do it themselves, some want the surgical department to do. Just figure out who usually does them in your team. You want to make sure that the patient goes with all the clinical notes and obs charts if it's not electronic. You want up-to-date blood, so up-to-date sort of within 48 hours pre-procedure. And you want to include FBC, USNEs, INR, because we're worried about bleeding, and that's often the contraindication for many procedures, and LFTs, because that informs your synthetic function of your liver. And often, actually, there's no need to be a nail by mouth unless you anticipate this to require, general anesthetic, or if it's a high risky procedure that has any risk to convert to an open operation. There's no need to stop heparin, Clexane, whatever it is, low molecular weight prophylactic that you're using when they come in, part of the VTE. And if it's inpatient, an emergency or semi-emergency situation, there's often no need to stop the aspirin clopidogrel as well. That's okay, we usually can manage that. But if it's a scheduled elective outpatient procedure, then there is advice to say that, if you're on clopidogrel, stop it 7 days before if you're able to. Other anticoagulations can be a bit more difficult. Warfarin, often you want to bridge it with low molecular weight heparin pre-procedure and stop pre-procedure, but have a discussion with your radiologist what other risks they're happy to take or what the procedures are. NOAC, it depends again. Every drug has different half-life. And with this situation, the INR may be completely normal, but there's still more bleeding risk than otherwise. Heparin is usually what you encounter if you're on a vascular rotation, and this usually is stopped up to 3 hours pre-procedure and requires some good communication between your team, the nurses, porters, as well as the radiology team, because you're going to stop it in time for the radiologists to perform their procedures. And just be mindful about the samples that are coming out if you're putting any drains in, that's all. Okay, so if any of this interests you, just ask to observe the procedure. After a couple of weeks on the ward, you know how things are, and there's always a bit of a lull in between where in the afternoon, and ask to come and see. It will inform you better, and you can talk to the next patient a little bit better about what the procedure they're going for entails. And if that piques your interest, arrange for a taste a week. You get up to 5 days. in F1 and another 5 in F2. So certainly make some time to come down to the department. Thank you very much.
Well, thanks, Miraen, for that. I think it's a really useful talk for sure. It really helps about knowing, obviously understanding the procedure and knowing the reason for it, but especially the pre-op things and the post-op complications are really important because that's usually your job. So
yeah.
As an F1, you're doing the pre-op bloods, or you're liaising with the IR department, or discussing the referral, and then afterwards the first person the nurses will call is you, because when they think there's a complication, they're going to say, hey, who's the F1? Let's tell them. So often you're the first person who reviews these patients, and you don't need to know how to fix a hematoma, but it's worth knowing what are the complications of the procedure and how does it present and when do I need to escalate, and which ones are real emergencies. And I think that's really, really useful to know. I mean, most of the IR procedures are job specific, but the ones we've covered here are quite general. And so almost every service will see an abscess drainage or central lines or things like that. Obviously, if you're doing an oncology job, then you'll see much more complicated things. Or if you're in a vascular job, yes, angioplasties, but EVARs and things like that. So there's no end to the complexity of IR procedures, but I think knowing the basics and kind of treating it like a surgical referral. So they're going for a procedure. So what would you need pre-procedure, consenting, et cetera, And I think if you think about it that way, then you'll really go far in helping a team really help, well, at least get the patient to IR and get them the treatments they need. We do have a couple of questions. So we've got about 10 minutes for questions. So I'll start with a kind of clinical based ones and then go on to a few which are about how to arrange a taster week and things like that. So we've got one on why would you use a tunneled PICC / central venous line. So maybe if you go back to the indication slide and we can talk through that.
Oh, okay, yeah. There we go. So the tunneled catheter or PICC line, they're similar. And the idea of these are just for longer term IV access. So cannulas, as you know, once you put in, there's often a very big sticker and your nurse is chasing you, being like, it's been 72 hours, that needs to be changed. So if you anticipate anything like that, then you want to think about having a central venous access, so either Hickman or PICC. If you're thinking of TPN or chemo, so something that's more irritant to the skin as well as the vessels, then you want to go into a bigger vessel, that's all.
Yeah, and I think length is key, because even a central venous catheter, you can only put on leave for about 10 days or so before you have to take it out. So a PICC line can be in for months, or a Hickman line can be on for months. So particularly if it's more than a week or so, then you should think about getting long-term access.
Yeah, exactly.
You don't want to keep changing your access, because that's just really annoying, basically.
Yeah.
In fact, so we've got one on what advice would you give medical students when learning basic radiography principles, or the basics of imaging?
I would say, basic radiography. I guess it depends on what your med school already covers, but otherwise, as you know, a lot of the way that clinical practice is heading now, it's very imaging heavy. Most people are almost getting a CT scan as they arrive to hospital, and a lot of decisions are almost completely changed depending on imaging. I would say, obviously, I mean, the way I've learned it is through YouTube videos mainly, and there's a lot available. Radiology is a very visual specialty. If you go on Radiopedia, they have quite a lot of free courses that talks you through the basics of X-ray, basics of CT. I mean, there's one in particular that's called the Pac-Man, because the most difficult thing in CT abdo-pelvis is just to follow the bowels through the abdomen. And I would say, unlike other things in medicine, it's quite difficult to learn it through reading words, etc. It's more dynamic, and certainly there's a lot of resources, Radiopedia especially, that helps you with that. So I'd say a lot of what I know or know well would be from Radiopedia rather than anything else, and their video tutorials, not the words.
Yeah, I mean, I'd echo that advice for sure. Radiopedia is fantastic, and there's loads of cases. I mean, I think it depends how much detail you want to learn. I mean, in med school, I think you've got to focus on knowing the conditions and knowing the treatments, because I think having a baseline of clinical medicine, even if you want to do radiology, is so important. Like in Dr. Lasker's talk, I think one thing that really came out was that actually you have to know the clinical presentation and the likely diagnosis, because that informs what scan you do. So I think that's obviously the priority. But if you want to learn a bit of radiology, it's quite underrepresented in most medical school curricula. And I think that's true generally speaking. I know some med schools are the exception, but most don't have a radiology placement and maybe just have a few lectures. And often they're just a bit boring. So I think often doing an SSC is great because you get a dedicated time to be in radiology and then you understand the basics. So if you do get an opportunity to do a student selection component in it.
Is that you?
Sorry, that's me. That's a fire alarm test.
Okay. I'll take the last question. I think he wanted to encourage SSCs as part of medical school, and I highly recommend that. But at the same time, I would say the only thing with radiology is not very much a spectator sport. So you could go there for a taster and you're just watching someone report, and it can be quite boring. So the main thing is to build on what you already know and ask a lot of questions. So like, oh, this gray here, is that the same thing as, is that still fat stranding, or is like something completely different? Cool. Moving on to the next question. So someone asks, how does one set up a taster week at another trust? They feel that their local department isn't good. Just email. So what I've done in the past is actually Google, whatever tertiary university center that you think has very good radiology services for whatever reason, maybe word of mouth of what you've encountered in your clinical practice. They often have like a directory and they have the consultant's name and email. If not their personal email, certainly a department email, and just say, hi, this is who I am, foundation doctor, etc. I'm interested to come and spend some time and see how you go. If you don't get a reply, send another one. I think for my last taster, it took me 4 or 5 tries, different consultants, before I actually got someone who said, yeah, okay, fine, I'll take you on for a week and see how we go. But it's quite difficult for them because, the workload is really high. They're reporting 20, 30 scans a day, and it's not a spectator sport. So it's very difficult for them to sort of entertain you while they're trying to do their work. Cool. I think his fire alarm is still going. What advice would you give to those who considering going to radiology? Absolutely go for it. I mean, it took me a while to get here. It took me 2 tries to get in. I think it's getting more competitive, but don't let that put you off. I think there are things happen for a reason, and certainly there are a lot of easy points to score and a lot of good talks on how to get into radiology, done both by IRA juniors as well as SRT, which is the Society of Radiology Radiologists in Training, as well as the BIR, which is the British Institute of Radiology. So they often put quite a few webinars on closer to the application cycle. Otherwise, have a chat to your registrar, ask them, let them know that you're interested, and they'll, if not immediately offer, they would bring it up in the conversation that you'll need to do some audit of some sort to show and demonstrate interest in radiology. So they'll probably be able to help you with that. If they can't personally, certainly signpost you to someone who can. Okay, and I think we have time for one more question. What societies and conferences this year would you suggest to build your portfolio? So I did the Society of Radiologists in Training, so SRT conference, which is just gone. But equally, there's a lot of medical student or medical school societies or undergraduate societies that put on similar events that are cheaper and more accessible. And there's no sort of tier to it. It doesn't have to be an international conference for you to really demonstrate interest. It could be an undergraduate society webinar. It doesn't, the marks don't differ in that way. The other one that's quite useful is the Yorkshire Imaging Society conference. I think they do it in December time. But all of it, actually, there's an active calendar on IRA Juniors that you can have a look. So it's updated regularly and lets you know when the next couple of events are. Pfizer read your question. I'm not sure I understand what you mean. What I want to get off in this expensive medical is TPN. I'm not sure what you mean if you want to contextualize that a little bit more. But otherwise, if there are no other questions, and Indra's fire alarm keeps going, we might...
Yeah, sorry, I've managed to find a slightly quieter place. I don't know if it's a test or not. I'm sorry, guys, it's really awkward. Yeah, if we haven't got any more questions, and we'll wrap up. But if you email us on iradjuniors@gmail.com, we're happy to answer our questions and give careers advice and things like that, because I mean, as Miraen will say, we're both really interested in IR, and it is a great career. So for anyone who's thinking something practical, or you like imaging, then definitely think about it. We're happy to give you advice on taster weeks and electives and anything like that. So if you just get in touch with us and keep an eye out for some of our future events, then yeah, we'll be sure to help out in the best way we can.
Bro, cool. I think should we call it a close?
And if you could fill out the feedback form as well, that would really help us, because we haven't run this session before. So we'd love to hear what you thought and some topics for next time. And we'll try our best to kind of keep running educational events and things like that, and go from there.
Brilliant.
Thanks so much for attending.
Thanks for attending, everyone.
Cheers.